Okay. When we're talking post-operative phase, this is the time frame from when the patient leaves the operating room until the time the patient is recovered. And this is at home. Okay, so the post-operative phase is a long length of time. Okay, it's not just an hour or so. But it starts when the patient is actually transferred to the post-anesthesia care unit, or PACU. If the patient is really critical, the patient may go from the OR to the intensive care unit. They may bypass PACU, and then they'll do their immediate recovery in the intensive care. Okay? But when a patient goes from OR to the PACU, which is where the majority of them are headed, they are accompanied by the anesthesia personnel, and they're accompanied by the circulator. Once the patient hits it, now the circulator has already notified the PACU that the surgery is over and they'll be there in such and such amount of time. Okay, giving them a time frame to let them know, get ready, here we come. So when they get to the PACU, the first thing that they do is they give a report, a handoff report, to that receiving PACU nurse. So report has got to be very clear and concise. Okay. There doesn't need to be any kind of distractions. That nurse can't be taking care of one patient and listening to report on an incoming patient. It's very important. Usually they'll have a standardized information that they go through, and you guys will see this when you start to learn to give report. Okay, you'll have your way of doing it, you know, and you'll have the items that you need to touch on. So when an operative nurse and anesthesia are giving report to the PACU nurse, there are certain things that the PACU nurse needs to know in order to continue the care of that patient. Okay, so they go over, this is so-and-so, and this is what they had, and the anesthesia time was, you know, she needs to know how long that patient was under anesthesia. In your book, don't ask me the page number, I can't remember, but there is a table, of course, that gives you an idea of the information that needs to be given. What page is it on? 285. Okay. We're now in chapter 18, guys, of the information that needs to be given. Okay. Handoff communication is a huge deal in healthcare, and it's even more important in this setting because your patient most of the time can't speak for themselves. Okay, so the PACU nurse has to know what's going on. Okay. In the postoperative period, you need to realize that every patient has certain risks, okay? They are all at risk for pneumonia. Everybody who has surgery has a risk of shock. When I say shock, that means they've lost fluid, blood, okay, to where the body cannot compensate for that loss. Okay. They all have a risk for cardiac and or respiratory arrest. Every operative patient has a risk of venous thromboembolism or deep vein thrombosis, VTE or DVT, and that's the way you'll hear me talk about it because those other words are just too big to pronounce, and I talk too fast. So, DVT or VTE, we'll talk about those things. They all have a risk of GI problems, especially GI bleeding. Those concepts right there are things you need to think about when you have a postoperative patient, because some of your therapies, your interventions, your assessments are geared toward reducing the risk of these things right here. Okay. So you think about any patient that comes into the hospital, period, has got issues with or potential risk for respiratory complications. They have a potential risk for infection because they may catch an infection in the hospital. They have a risk for immobility issues because we bring them in and we stick them in the bed and we may let them get up, we may not. So when a patient's hospitalized, or, we have to think about those are the concepts that we're concerned with. Now we're throwing a surgical procedure into that mix. We've got these other things we've got to think about, okay? So in addition to that is maybe look at what the patient had. What kind of procedure did they have? That adds other risks on top of that, okay? So you got to look at the whole picture. Just because the patient had surgery, we know the patient has a risk for pneumonia. They have a risk for those things we just talked about. So we got to be diligent and look for those things, okay? So when the patient gets to the PACU, these are the PACU's priorities. This is what that nurse is really, really, really trying to focus in on. ABCs: airway, breathing, and circulation. We're trying to get our patient back from their anesthetic state. We're trying to stabilize our patient. We're trying to prevent hypoxia. What is hypoxia? Decreased oxygen level. Getting oxygen to the tissues. All right. We're trying to prevent hemorrhage. And we're trying to prevent injury. So, this is the PACU priorities. Do you think this is a priority out on the floor as well? Yeah, it is. So, it's a little confusing. It's kind of hard to say, here's what the PACU's issues are, and then here's what the floor nurses' issues are, or the ICU nurses, because it carries on. It's a post-operative patient. So, just know that if I'm out on the med-surg unit and they're bringing me a patient from OR, I am concerned that they're not hypoxic and they're not hemorrhaging. Okay? But in the PACU, those are my main focus. Okay? We've just closed the wound. We're just now trying to wake them up from surgery and get them to breathe in on their own. Okay? But it does carry on through there. So when your patient gets to the PACU, immediately you've got to have an assessment on that patient. Right? Immediately you are assessing ABCs and level of consciousness. Your patient may still be intubated from surgery. Sometimes they just don't wake up really quickly, so anesthesia may have opted to keep the patient intubated, or they may be so sleepy that they can't keep their tongue from falling to the back of their mouth, so they may have an oral airway in to keep the airway open. Okay, so there may be other things going on there. You have to assess the gas exchange. Sometimes they've extubated the patient and they're doing okay, but then they get to the PACU and their O2 sat has fallen to the 80s. Maybe then you need to put another airway in, or they need to put another airway in. Okay, so immediately report and assessment. We are going to assess the vital signs. Got to get the baseline for when they reach you in the PACU. That's the first thing that you're going to do when the patient gets back to your floor. ABCs and get their vital signs. Okay. we want to put our patient in a semi-Fowler's position if we can. Sometimes the surgery says we can't. Okay, but try to put him in a semi-Fowler's. Why? Why would that be the position I want to put him in? Good chest expansion, decrease the risk of aspiration if they vomit. Okay. People get nauseated and pukey when they're starting to come out from under anesthesia, so we want to try to maintain that airway. If we cannot put them in semi-Fowler's, maybe we can put them on their side, or we can put them with their head turned. Remember all that stuff you learned about prevention of aspiration? That's one of our goals there. Okay. Got to do a brief head-to-toe assessment. And you're especially going to zero in on those areas where the patient had surgery. Okay. We're wanting to look at any kind of tubes that the patient has. You've got to look at their dressing. Remember, I'm concerned with hemorrhage. So look at what bags they've got hanging, what fluid is hanging and infusing. Look at their dressings. Sometimes, like we said, they'll have a drain in. You need to look for that drain. And then you're going to look at the orders that you have. Get your patient put to bed, assessed, and stable. Then look at your orders. You may have some stat orders that you have to do right now. And the anesthesia people and the circulator are going to help, get your patient positioned and moved and all like that. And make sure everything is settled, and then they go back to where they came from. Okay. Unless it's like an emergency kind of thing and they got to get back to the room. But usually they're pretty good about, helping you get the patient set up. Okay. So why do you think a patient post-op would be hypoxic? What would lead a patient to be hypoxic post-operatively? Huh? The drugs that they were given, the anesthesia, it makes them lazy. They don't want to breathe. Okay? It depresses the respiratory system. The patient is unconscious and they may not be able to keep their tongue pulled away from the back of their mouth. It blocks the airway. Anesthesia depresses their cough and swallowing reflexes. Patients coming out of surgery have to be suctioned sometimes if they can't manage those secretions. So suction is one of those emergency things you have to have available to help maintain that airway. And then your patient always has a risk for laryngospasms and bronchospasms that can actually occlude the airway. So how am I going to know my patient is hypoxic? What tells you your patient is hypoxic? They're cyanotic. What else? Now that's blood flow. When you're talking capillary refill, that's blood flow. Okay? But what do you notice about their nail beds? They're blue. Right. What else? Their O2 sat is decreased. So I would think that when the patient comes through the doors, anesthesia is going to say what the anesthesia time is. They've done well. Yada yada yada. O2 sat at the end of anesthesia was 96%. Upon leaving the OR, O2 sat was 99%. So you get the patient put to bed, you hook them up, you stick that thing on their finger or their earlobe or wherever you opt to put it, and it is now 92. It's dropping, okay? So hypoxic, you look at their O2 sat, you look at their color, okay? What else? Labored breathing, absolutely. What is their respiratory effort? Are they struggling to breathe? Do they have stridor? What is that? That's that high-pitched kind of sound that they have when the airway is occluding, like when they have bronchospasms. Okay? Weird breathing. A lot of snoring. Okay? Now, people snore after anesthesia. Okay? So you just have to wake them up and say, take some deep breaths for me and that kind of thing. So, but when you start to hear stridor, that high-pitched kind of sound, that's occlusion. That's not right. You got to fix that. Okay? So, assessment of your patient, respiratory effort, look at their color, look at their O2 sat, listen to their lung sounds. If they're still intubated and they're blue, maybe the tube came out of place. Maybe the tube's dislodged. Assessment, assessment, assessment. Okay. So what in the world are we going to do for it? My gosh. What do we do for it? Give them oxygen. It's that simple. Hook them up. Get them 100% oxygen. Stimulate them to breathe. Keep waking them up. No. Not in the PACU setting, no. That's a given. That's a given. Anesthesia is right there. Every patient post-operatively needs oxygen if they've been put to sleep. I've never seen a patient not get oxygen after OR. Again, you're using it too to blow off some of that inhalation meds. So hook them up. Hook them up. Give them 100% O2 or what you need to give them, but mostly it's going to be 100%. All right? How about hemorrhage? Woo, there's a biggie. Hemorrhage may be external. That means it's coming out. You can see it. Okay? Or it may be internal. The person is bleeding on the inside and you don't know it. Okay? But these are signs and symptoms that your patient is hemorrhaging. I would know them. I would know them. I would know them. Because people can bleed from anything, right? And if people are losing blood, you need to know what to look for, how your patient's going to react, and then what you need to do about it, okay? So what happens when the patient first starts to lose blood? The body compensates for a while, right? Everything kind of stays okay. The heart rate will go up a little bit. The respiratory rate will go up a little bit because it's trying to get blood flow to those areas, and we don't have quite as much blood as we had. Okay, so everything kind of speeds up a little bit to try to get blood to the body, to the rest of the body. As a result, the blood pressure drops a little bit. Okay, as hemorrhage continues, less and less circulatory volume, pulse becomes weaker. The patient's skin becomes cool, damp, pale, and the patient is restless. The patient has a sense that something is not right. Okay. Sometimes you have no other sign other than the patient is restless. Okay. You have a patient that's brought to you and they're fine, they're quiet, their vital signs are steady. Suddenly the patient becomes very restless. What do you do? What are you going to do? You're in the recovery room. What do? You assess. What am I looking at? Let's look at first thing I want you to do is look at their oxygen saturation. Okay? Are they breathing enough? Okay? Oxygen sat, look at their vital signs, because they're usually on a monitor that's going to give you those figures, right? Then I want you to look at their dressing. Okay? Look at their dressing. So look at vital signs. Usually your vital signs, oxygenation is going to be your first thing you're going to look at. Airway. Okay? You're kind of doing it all at the same time. I know y'all hate that, do this first, second, third, and all that business, because you're all really doing it all at the same time. But look at your airway first. A lot of times that's what it is the patient just needs to take some good deep breaths. But then you've got to make sure that they're not hemorrhaging. So look at their dressing. Palpate around there. When you look at their dressing, you've already looked at it on admission. Okay? So when you put that patient to bed and you looked at that patient's dressing, if there is drainage on the dressing, what you do is you take a Sharpie or a pen and you draw around that wound shadow. Okay? So that when you go back and you assess it a little later, whether the patient is restless or not, if it was this size and now it's this size 15 minutes later, I might be a little concerned. Okay? So that's the way we monitor drainage on a dressing, is by outlining it and then outlining it again. Okay? And then you're kind of timing to see, do you think it's excessive? Okay. We expect patients to have drainage on their dressing post-op. Okay. They're bleeding. They're going to bleed. But it shouldn't be a huge, big, saturated dressing. Okay. So we expect them to bleed. Don't freak out just because they got a little blood on their dressing. What you do is you go back and you assess it again, and if it's really progressed, more than you think that they should have, then you have to, make sure that we don't have a hemorrhage issue going on there. Okay? So in the PACU, what we're going to do is we're going to maybe reinforce that dressing, maybe put more gauze on top of it. We don't take it off and put it on, and we certainly do not remove a pressure dressing without an order for that. Okay? And usually your post-procedure orders will say pressure dressing times 24 hours. So at the end of 24 hours, if there's not anything going on, that's your order. You can remove it. But in the case of just a plain old dressing, we reinforce those dressings. We reinforce pressure dressings as well. Okay, just stick some more gauze on it, put it on pretty tight. Okay. And if you're constantly having to reinforce the dressing, then we need to call the physician. Okay, it's a judgment call. I wish I could tell you if you have this within this amount of time, call the doc. It's a judgment call. Okay, if instinct tells you you think this patient's bleeding too much, just call. Put your mind at ease. Okay. So hemorrhage, we're going to see these signs. But we may not see the blood coming out. It may be internally. An abdominal surgery, if they're bleeding inside, what do you think happens to the abdomen? It distends. It gets very hard to palpation. Okay. So assess your patient. Look for these symptoms. And then we're going to reinforce the dressing if we need to. We may need to just hold pressure. Okay? I have held pressure on a wound for about 45 minutes until the physician can come in. And you just do this and have a seat. Okay, nothing you can do. You got to hold pressure. And then notify the physician as needed. The physician is who you're going to call for hemorrhage. Okay, respiratory issues we're usually calling the anesthesia people, but hemorrhage, that's a surgical issue. Remember, the surgeon handles the surgical issues. Okay. Your patient is also risk for injury is the other thing that we're concerned with in the PACU too. Remember, they've got a very decreased level of consciousness because we've put them to sleep. And then they've got lack of sensation if they've had a regional or a spinal type anesthesia. So again, when they get to the PACU, we're going to look at positioning, especially if you've got these floppy extremities that they can't control. You know, good positioning. Keep the side rails up on the stretchers or the beds, whatever you're using. We're not usually using straps at this point because they're usually on a gurney that's big enough for them. But we do need to keep the side rails up. No falling in the PACU. That's hard to explain. Hard to explain that or in the OR too. Okay. Patients are usually discharged from the PACU when they meet criteria. And that varies from place to place, but it's pretty much when your patient is stable. Okay? They usually can awaken pretty easily. Now, they're still going to be drowsy, okay? But they awaken pretty easy, or they may stay awake. Their vital signs are stable. You're not having any kind of excessive bleeding or drainage. Respiratory status is good. They are maintaining an O2 sat above 90. And then you've given report. And this report is to the receiving unit, whether it's the outpatient department or the intensive care or the med-surg unit. But again, you're going to give a good detailed report to them about what the patient had, how they did in surgery, and then how they did in PACU. Patients that are in PACU are fussy. You know, they're waking up, they're groggy, they're irritable. You know, so you have to be aware of that, but that should improve while they're there. So if you've had to give any kind of medications or do any kind of treatments, therapies, anything like that in the PACU, that needs to be told to the receiving nurse. I need to know if my patient had to have 20 milligrams of morphine in the PACU, because I'm going to need to get some morphine when that patient gets to me. Okay? I need to know if their O2 sat kept dropping into the 80s. Okay? Some patients are planned returns to their med-surg unit, but because of the way they, recover in PACU, they may decide to send them on to the ICU for some extra monitoring overnight or whatever. So they may not automatically come back to you. Usually they do, but sometimes they choose otherwise, okay? But that's usually your basic criteria. Once the patient meets those, then the patient can automatically be sent to wherever they're going. Okay? If they're going back to the outpatient department, they can be discharged home from the ambulatory department. But again, they've got to meet criteria as well. Varies a little bit from place to place, but this is pretty standard. Pretty standard here. They have to have their pain under control. We don't pop them with a big dose of narcotics and send them to the car. Okay? We give it to them, make sure that they're good and stable, steady. They haven't had anything for the last 30 minutes or so. Very little nausea and vomiting. They have to have voided. They have to be able to get up and move and ambulate, provided that's what they can do. Now, if they've got, a big old cast, we're not going to hold them to that, but it's got to be age-appropriate movement and, based on what's going on with them. They must have a responsible person to drive them home. And then they can also go when they're able to understand their discharge instructions. So they got to meet PACU criteria, which is basically they got to be stable. And then when they get back to their outpatient unit, they've got to meet these other things too before they can go home. Not everybody meets it, but the majority of the patients that you have in outpatient meet this criteria and get to go home within an hour or two. Okay. Questions about that? Yes, ma'am. She asked about who does discharge instructions. Usually the physician will order what they want discharge instructions, okay? They can take a bath in 48 hours, tell them to come back and see me next week, keep, the wound elevated, keep the cat, those kind of things. A lot of your outpatient departments have standard discharge protocols and instructions for specific surgeries, okay? If your patient has come in and they've had a laparoscopic gallbladder, and they're going home, they have those standard things that physicians have already signed off on, but it's like an order sheet and the physician will sign it, and then the nurse will go over that with the patient. Okay, so the nurse is the one actually giving them, but the physician has ordered them. And it's basic stuff like when they can bathe, when they can eat, what is their activity limitations, okay, how to take care of their wound, when to come back and see the physician, what to look for, signs and symptoms of problems, when they need to call the doctor, rather than, and they're usually kind of specific, rather than call the doctor if you have a fever. It's like, call the physician if you have a fever above 102. Okay, we expect them to have a little fever after surgery. That's the body's response to surgery, right? So, but when it starts getting 102 or so, that's an issue. Okay, so it's usually spelled out, and we usually give the patient a copy of those. They usually go out with written instructions so that they have them there. Right, the doctor tells them about the surgical procedure. And then we tell them about the flow of events, what they can expect to happen that day. But the doc is responsible for telling them about the surgery, risks, benefits of the surgery, what other therapies are available if they didn't want. Correct. You can always verify their information and redo it. I worked for a physician one time, several years, and he's Indian, and you think about it, you have a patient that comes in that's elderly and they don't hear very well either, and he was a surgeon, and he would be talking to them about the surgery, and they would be shaking their head and just grinning and being all, he would walk out of the room and they would just look at me like, what did he say? They would not have understood a word that he said. So then I would have to just interpret and say, this is what he said, and then if they still wasn't getting it, then he had to come back and write it out or do something, but because it's ultimately his responsibility. But yes, we can always verify and validate that they understand what the physician has said. Right. Okay. Any other questions? Are we tired?